Yeah, good morning everyone. So the topic for my paper is central toxic keratopathy post collagen cross-linking. Slides are not moving. So I have no financial disclosure to disclose. So the purpose of this study was to report a case series of central toxic keratopathy post collagen cross-linking in keratoconus. It was a retrospective case series which included 12 eyes out of 964 eyes who underwent collagen cross-linking for progressive keratoconus, and the protocol followed was epithelium of accelerated protocol using the Avogadro KXL cross-linking system. After the CXL, BCL was applied for 1 week along with the routine topical medications. So out of the 12 patients who had developed CTK, there were equal number of male and females, and the age group was between 16 to 32 years. This is a table which shows that almost all the patients presented to us within 1 week of post CXL, and all has the characteristic features of the CXL, which I will be discussing in the subsequent slides. So we can see when the patient presented to us at 1 week with this clinical picture, where we can see there is a central stromal opacity along with striae radiating from the opacity. There is no any congestion of the conjunctiva. Important to know, there is no any epithelial defect and no AC reaction. So the location of the opacity was central, not peripheral, with very distinct borders along with underlying stromal thinning. The ASOCT shows the hyperreflectivity where the opacity is present, and the hyperreflectivity was more in the anterior stroma compared to the posterior stroma with a characteristic inverse dome-shaped pattern. So this was the topography of the patient, which shows that there was a significant corneal flattening compared to the preoperative level. The confocal microscopy shows the activation of keratocytes, but there are no any inflammatory cells. As we can see, over the time the opacity fades away, and ASOCT shows there is significant stromal thinning just below the opacity. This is the graphical representation which shows that there is significant, in the acute phase of CTK, there is significant corneal flattening, and in the remodeling phase the cornea regains, becomes steeper, but the steepness is still less compared to the preoperative level. Also, the pachy of the thickness of the stroma decreases in the acute phase of CTK. So the CTK, it is a non-inflammatory self-limiting condition which is commonly seen after the laser refractive surgery, most commonly after LASIK, where we can see there is stromal tissue loss, striae, and due to the stromal tissue loss, there is significant hyperopic refractive shift. Important thing to know is that it has not been reported post-collagen cross-linking. So as there is loss of stroma, the anterior surface falls back to fill the gap, causing flattening of the anterior surface of the cornea and hyperopic shift. So these are the probable external factors which play a role in the formation of CTK. The topography shows over the period the significant flattening, and in the remodeling phase the cornea becomes steeper, but the steepness, as I told, is still less compared to the preoperative level. So due to the stromal remodeling, there is increase in the corneal thickness, which causes change in the refractive index of the stroma, resulting in reduction in the hyperopic shift after the remodeling phase. So the diagnostic features on tomography include the exaggerated anterior corneal flattening with corneal thinning. ASOCT shows inverse dome-shaped opacity with backscattering, and the confocal microscopy shows no inflammatory cells. So it is a self-limiting disease which resolves spontaneously in 2 to 18 months, and the topical steroids have no role in the treatment of this condition. On the contrary, it may worsen the disease. So CTK can occur post-collagen cross-linking. It is a non-inflammatory condition, self-limiting, and topical steroids are better to avoid in this condition. Thank you.